welcome to today's second lecture, or this week's second lecture of the week. This lecture is going to focus on some specific screening tests that we are offering patients today in our prenatal care. There are two types of screening tests that are offered now. We are actually offering parent carrier screening so they can find out if they are carriers of any genetic issues. And we are also offering then genetic tests to the mom that she can do to find out if the fetus has any genetic issues. So the previous lecture kind of talked about overall genetics. So I wanted to focus more specifically on the tests that are offered that you will be offering your patients in clinic. So let's dig into that today. So as a review, we need to remember the difference between a screening test and a diagnostic test, because I think oftentimes our patients get a little bit confused with this, especially since some of our screening tests are really excellent and can screen up to 99 and 97%, and so they get a little confused with those numbers. So let's remember that a diagnostic test will give a patient a very definitive answer whether or not their baby has this, and it will tell us for sure. And the only diagnostic test that we offer will be an amniocentesis or chorionic villi sampling, or also known as CVS. I stay away from saying that because they get it confused with the drugstore. But and direct DNA testing. The direct DNA testing, though, although very, very good, is not considered diagnostic. So we need to make sure they know that. Even though they are considered diagnostic, even our amniocentesis and CVS have about a 0.4% false positive rate. Tiny, and in my entire career, I have never seen one come back wrong, but in theory, they do have this tiny false positive rate, so just to know that. Screening tests look to determine the level of risk that your baby or this person will have for a certain disorder or disease, and then we use that information to then say, it's worth it for you to go through this diagnostic test, because like an amniocentesis carries some risk with it, a CVS carries some risk with it. So we do this screening test and say, it's worth it for you based on this information to take the risk and do this diagnostic test, or it's not worth it for you. Or the other thing is we look at your family history, we look at your age, we look at the genetic history of your family, and we think it's worth it for you to go through this diagnostic test because of all of these data points. And because of that, we think it's worth it for you. So balancing all of that information. And so I hope that makes sense. And so we take all of that into consideration. So when we look at screening tests, there's 6 things. I'm getting really deep here, maybe more than you need, but there's 6 things with all of our screening tests. And this kind of even goes back to some of the research, when you look at research. But we always want to look at 6 things. We look at the sensitivity of a test, the specificity, the false positive rates, the false negative rates, how good it is at positively predicting, and if it has a negative predictive. I'm not going to go too deep in the weeds on this because Varney does go through it quite well, and Williams actually goes through it quite well, but I just want to touch on it a little bit, because especially sensitivity and specificity. So specificity, and try to say that 10 times fast, is if a lab is proven to be 90% specific, it means that if there are 100 people that took the test, only 90 of them will come back with results that say they are. So if 100 healthy people came back and took the test, only 90 of them would actually come back and say they were healthy. 10 of them would say they were unhealthy, even though they were healthy. Does that make sense? So 10 would actually be healthy, but there would be this false positive result or abnormal findings that would be inaccurate. So it's specifically correct 90% of the time, but 10% of the time the test will be wrong. So it's a good test. It captures, it's 90% of the correct 90% of the time, but 10% of the time you're going to have a wrong answer. So 10 of those people, or 10% of the time, they're going to have to go on and have a diagnostic procedure to confirm that they're actually healthy. Okay, so I hope that makes sense. So if you have a test that's 90% accurate in screening people, that means that you're going to get 10% of the time, you're going to get individuals that have a completely healthy baby, but it's going to show up saying that their baby isn't healthy, and we're going to send them to have diagnostics done. Or maybe, and then it'll turn out that their baby is fine. So we would never want someone to go and do a termination or tell them that this is really bad news and so go have an abortion based on a screening test alone, because if it's only a 90% specific test, it could be that their baby is one of those 10 that is completely healthy, and they would terminate a completely healthy child. So it's always important that we always go on and get that diagnostic test before doing anything permanent. Sensitivity, if a test is determined to be 90% sensitive, let's say for liver disease, so if 100% of 100 people are tested, this would be where, let's say 100 people with liver disease were tested, they would find 90 of them, but they would miss 10. So 10 people would say, you're fine, but really they're not fine, and that's a false and negative. So this part it's dangerous because we actually want to find those people, but we're missing them. So for example, that's why we do the 2-step glucola screen, because there's a sensitivity piece that's missing with that 1 hour level. And so we do the 3 hour because that the sensitivity with the 1 hour isn't high enough to capture all of those people, but the 3 hour is. So we'll screen most of them and it'll capture most of them. So we'll want to capture the rest, and that isn't maybe the best example, but you get my point. So positive or negative predictive value is the probability that those with a positive result in a screening test may or may not have the disease, or may have the disease, and the negative is the probability that those with a negative result have the disease. I hope you're following me on this. So, and this is a complicated formula that's tracked over time, and I'm not going to get too deeply into it because, like I said, Varney goes through it if you want to know more. So the screening tests, there are 3 categories of fetal screening tests. We have the biochemical, where it looks at proteins and enzymes produced by the genetic code, but it doesn't actually look at the genes themselves. And these can be screening or diagnostic. There's cytogenic testing that looks at the actual chromosomes for abnormalities in the structure of those chromosomes. And then you have molecular testing, which actually analyzes the DNA or looks for DNA mutations. So we have first trimester screens that we do, and most of these are recommended to do between 10 and 14 weeks. So this first one is a combination of an ultrasound and a blood test that we do to mom. We are looking at maternal serum levels of 3 hormones. It's PAP-A, HCG, and I thought there's a third one, maybe it's just 2. And we see increased levels of trisomy 21 when she has this low PAP-A and high HCG. And if we just look at these serum markers alone, we'll actually detect 67% of trisomy 21 and 80% of trisomy 18 and 59% of trisomy 13. So it's actually a pretty good number just with the blood work alone. But if we throw in that nuchal fold translucency screen with the ultrasound, we increase the numbers even further. So it's a dual screen. So that combined detection brings it up to 90% for 21, 97% for 18, and 84% for trisomy 13. However, it's a little tough sometimes, especially in our low resource clinics, to get women in for this dual screen. Plus, it's a pretty it's a tough. Your ultrasound techs have to be trained. It can be a hard measurement to get in. Sometimes it's sometimes we're not seeing our patients. We have to measure it. The ultrasound has to be done before 13 weeks, 6 days. If it's done after that, we miss that screen. So there's been some barriers to getting this particular screen done. The other test that's done is this free cell DNA, often referred to as NIP or non-invasive prenatal testing. Screens for the same things, also sex chromosome aneuploidy, and it can be collected anytime after 10 weeks and then throughout the pregnancy. It detects 99% of trisomy 21, 99% of trisomy 18, and 92% of trisomy 13. However, you got to remember it's only a screen, it's not diagnostic. Recent research, I don't have this on the slide, does recommend that we also still do a nuchal fold as it increases further our detection rates. That was something that came out this summer. So they're still recommending that we do the nuchal fold translucency testing along with the screen. So some of the barriers are still in place, but even so, doing this blood test along with the nuchal fold translucency is the gold standard. Or just doing this blood test is also an option. If there's any positive result, usually the next step is to send them to genetic counseling with a possible CVS or amniocentesis, depending on where they're at in their gestational age. So that's first trimester screening. Second trimester screening, then, we can continue to screen them with a non-invasive testing if they desire. And just a lot of, to back up for a second, another barrier is cost, and I'm just going to pause for a second. So in my clinic, cost, we're finding if they're under the age of 35, the cost can be upwards for the for the non-invasive testing can be upwards of $600 for the blood work alone. And Medicaid will cover it up. They'll pay, the patients only have to pay out of pocket about $200, and it's applied to any deductible that they have, so patients will often pay for it. If they have a genetic history, it's covered, and if they're over the age of 35, it's covered. So right now, that's a big barrier for a lot of people. A lot of people like to get this because gender is determined by this blood test, and it's never inaccurate, and so they don't want to wait until their 20-week ultrasound. And so that's a big draw for people wanting to get this, which is, I think, a counseling piece and an education piece that you need to talk to them about. But so money can be a big barrier for people. The PAP-A HCG is covered a little bit more because it's been around longer, so insurance companies are a little bit more likely to cover. I don't know the exact amount on that one, but more and more people are wanting to do this NIPT because the screen rates are so high. So I think in time we'll see insurance companies being willing to cover and at higher rates. So pay attention to that and notice that in your clinical settings. Second trimester testing is we screen not only, in this test, we can screen not only for aneuploidy, but also for neural tube defects like spina bifida and anencephaly. And we usually start that screen around the 16-week visit. And this is usually referred to as the quad screen, the maternal serum, the alpha-fetoprotein, or the multiple marker test. And so these tests look at the alpha-fetoprotein, the unconjugated estriol, human gonadotrophin, and inhibin A. Only the AFP is a protein made by the fetus, and all the others are placental hormones. So this, like I said, is done between 15 and 20 weeks. We see decreased levels of the MSAFP with Down syndrome, and we see it increased with neural tube or multiple gestations. You can see we see unconjugated estradiol decrease with Downs. We see HCG elevated with Downs. We see inhibin A elevated with Downs. So again, this is just screening only. It's not diagnostic, and it's not a super high. It's only 60%. So with Downs and with the multiple markers. So our diagnostic tests. So that was all of our screening tests. So now the only diagnostic test that we have, and I just want you to know look at what the detection rates are. They're not as high as I would suspect, but our CVS, the chorionic veli sampling, it was done usually between 10 and 14 weeks, and that is a 98% detection rate, and that's in the first trimester. And then second trimester is amniocentesis, and that is a 99.5% detection rate. So here are the picture of both amniocentesis, and I'll talk about that a little bit more in a minute, and then the chorionic villi sampling, where they take this little bit of sampling here, using it goes through the vagina, and they use a little a speculum and a catheter that is inserted through the vagina to get a sampling of the chorionic space. And then in the amniocentesis, it's actually a needle that's inserted through the abdomen. They use the ultrasound to make sure they're avoiding the placenta, and then they're taking a sampling of the amniotic fluid. So with the chorionic villi sampling, it's performed between 10 and 13 weeks. It's used to assess karyotype, but other genetic tests can be done as well. The benefit with this is that if they do desire termination, it can be done early, and results take about 7 to 10 days to get. The risks are similar to amniocentesis as far as miscarriage risk goes. If it's done before 7 weeks, so we don't want to do it before that, there is a risk of limb deformity, so we try not to do it before then. And now it's pretty rare that they do it prior to 10 weeks. They're almost always done after that. And it's really normal to see vaginal spotting, whether it's because of cervical dilation or just because of the endometrial lining that's spotting. Amniocentesis is performed later, so between 16 and 18 weeks, so that that placenta has grown enough so that they don't risk nicking the placenta. That's the big risk. And so they want to make sure they get able to get enough fluid as well. The risk of pregnancy loss is 1 in 1,000, so it's a pretty small risk. It entails inserting a long, thin needle in through that abdomen. You saw the picture, and I have another one here as well, to get that sample. And you can see another picture here. I got it from the Mayo. And then they take fetal cells out of the fluid, and then to develop the chromosome look and the karyotype. And here's a picture of a normal female karyotype. So they'll develop out of whether it's from the CVS or from the amnio. They break down all of the fluids, and they look at all of the chromosomes and type them and look at them carefully to make sure that everything matches. And you can see here it's a female because there's no Y chromosome, just an X. And they look at all of the 22 chromosomes to make sure they match and that everything is normal. That's pretty cool, I think. So how do you help a woman decide what she should do, if she should do screening, if she shouldn't do screening, if she should do an amnio or not? So I think the biggest thing, first of all, is her age and her genetic family history. So we know that over the age of 35, her risk increases, and then if she has a strong genetic family history, those would be big reasons. The second thing is whether or not she would terminate if she had if she would want to terminate if she had an infant or a baby with issues. And this is where we really need to be careful to leave our biases at the door and just let her process this, her and her partner. If she thinks she would terminate, then we would want to recommend doing testing and screening early, because the earlier that she gets the testing and the answers done, the safer this process is for her. So we would want to encourage that as quickly as possible. Some women need to do screening because they have some anxiety or a lot of anxiety around this, and it is important that they need to know, otherwise they will feel much anxiety and stress through the entire pregnancy, so that the sooner that they can get answers and just lay these pieces to rest, the better. And so for those women, it's important for them to do this so that they aren't just feeling anxiousness throughout the entire pregnancy. And then I think other considerations, besides that anxiety or that piece, is that they need to consider the cost of the test. And if they don't really have a strong need to know, or they wouldn't terminate, or they don't have a strong family history, then the financial burden of this might be enough to say, we'll figure it out. I'm not going to worry about it. But I don't have $600 to spend, and I'd rather put that towards the nursery or put that towards whatever, or my deductible later on down the road. So we would really want to help them walk through all these different issues as they're deciding. Our role when we're talking through this is to make sure that we're communicating all of the information, and it is definitely a skill There's a lot of emotional information with this and a lot of ethical landmine that we're walking through. So it's important that we keep our own biases at the door and just really let this be an open dialogue where we're sharing this information openly and without judgment. Make sure you know your algorithms as far as like age and her genetics, when and where we need to send her and why. Be prepared to support her and answer questions that she may have. Just really, the more open and honest you can be and the more supportive you can be, that's really what she needs, in the space in which to ask those questions in a very compassionate way. And then be ready to refer to genetic counseling if that's appropriate for her, and it might be, especially if she gets a screening test that comes back positive, or if she has a very complicated genetic history. That's something that you'll want to consider. And then lastly, and just quickly, we'll talk about carrier screening. So the purpose of this is to detect couples that might be at risk for having children with a genetic condition, and we touched on that in the previous lecture. So ideally, we would like to do this before they have children, but sometimes this is done with a first pregnancy. And so these screen for things like cystic fibrosis, Canavan disease, Tay-Sachs, all of your thalassemias or your hemoglobinopathies, Fragile X, which is a part of the autism spectrum disorders, spinal muscular atrophy, and many, many more. So there's a lot of ethical issues with this, but they can be ethnic-specific screening versus pan-ethnic. We can do expanded carrier screenings. So right now, because of all of the different ethical issues, the expanded is the current recommendation for everybody, and just kind of know that. And I guess that's all I have for that. So if you do have someone that you're seeing preconceptionally, I would recommend having them or talking to them about this. They may or may not want to do this, and a lot of it depends on what their insurance will cover. Doing kind of a quick genetic history to see if anybody in their family has any genetic issues would warrant talking about this in more further depth. Oftentimes too, if we do come back with positive on the fetal genetic screen, then this is really where it's worthwhile to have this horizon, and then have this carrier screening done, and then have the partner also screened, so we can know what future babies or the risk for future babies might be. So there's lots of information that we can get, and then sending them to genetic counseling so they can see what their chances are of continuing to have children that have or may not have this risk. So there's so many opportunities for parents to learn about their individual risks, about their future risks. It can be so complicated when we add in the billing and insurances. And I know in my own practice, I think we accept something like 110 different insurances. So it's impossible for me myself to keep track of who has to pay what. And so we do have individuals that help with that. So it can become very complicated and complex so quickly when you want to help your patient to be a good steward of their money. So being mindful of that is important when you're counseling them as well. But I think just being mindful that there is associated costs with it that they'll want to consider as well. So I think that's the gist of what I want to say today. And I'm sure that this will be something that will be part of all of your first OB, and if not your second OB appointments. And hopefully the carrier screening will be something you'll have an opportunity to talk about at some of your preconception visits. So that is all I wanted to talk about. I do have some references here, and if you have any questions, as always, please post them in the general forum. Have a great day.